Controversy versus Clarity, Bedside Ethical Decision Making in ICU. This was a lecture I delivered today at the state-of-the-art meeting, the Excel Centre, on the 7th of December 2016. And on that platform was Dr. Chris Basford, as well as my colleague from Nottingham, Dr. Dan Harvey, in a forum of 3 ethical talks. This talk was designed to highlight one of the ethical approaches we have to decision making in Nottingham that Dan Harvey and myself have been working on and trying to teach and develop. Because you know what it's like. You're on the intensive care, you're bringing some order to the chaos, and everything seems to be just where you want it, when then the really difficult case comes along. And it's not difficult because you don't know physiologically what to do. It's difficult because of the decision making that you have to make. And often those cases come with complex family interactions and complex interactions with other specialties. And they really wear you down. And you head home, and you get home, and you're just thinking, wow, that was a bad day. And Dan speaks about having a cup of tea, staring into it at 2 o'clock in the morning, and a few tears coming down. I think we've all been there, though personally, I go for something a bit stronger than Dan. Obviously, Aussie Red. And you're sitting there going, this was really tough. This was a really hard day with really difficult decisions. A lot of them are very ethically complex, and I'm not quite sure I did what I wanted to, that I did the right thing. And you think, surely we were going to be taught this. How was I taught this? Well, there is a syllabus, and ethical issues do occur, 16 occurrences in the syllabus. But at the basic level, where it seems that if you can just spell non-maleficence, you pass the exam. Basic ethical principles for these complex issues. Well, you compare and contrast that to what we have to know in other aspects of our practice, like the arterial line waveform analysis. We got to know things about critical dampening and resonant frequency. And I'm not sure about you, but maybe a few tears were spilt in the first few, trying to work out what this thing means. But in my last 10 years of practice, I have not spilt a single tear or even barely a thought on what critical dampening really means and what resonant frequency is. But often at night, when you find yourself not sleeping, you find yourself tossing and turning, yelling at the kids, it's not your lack of knowledge of critical dampening that's wearing you down. It's the decisions you've had to make and the complex ethical decisions. And the problem is we feel like we're making these without competency. And we all know it's hard, and it's a huge form of stress and burnout for us all. And we need to work out how we can make these complex ethical decisions with competency. And what we feel is you need knowledge. You need application of that knowledge, which is a skill. How do you apply that knowledge? And you need an experience and mentor to help you through it. The apprenticeship scheme of intensive care still holds very strongly, and you need to do it in a safe environment. So, we're not going to teach you anything new today. We are still using the 4 principles that we all know and learnt at medical school. And those principles have been around since about 1979. Not as old as some people thought. They weren't handed down on tablets of stone. And there's been many versions of those principles where they're reapplied over and over again by Beauchamp and Childress. And one of the criticisms of their 4 principles is the fact that they're often in conflict. And how does that help? Well, we think it helps a lot, because what we think is that conflict, it shows you where the dichotomies are, where the areas are you need to invest your time and energy. In fact, the conflicts are part of its power because it highlights it to you. So how do you apply principlism at the bedside? Well, first of all, you need knowledge of the 4 principles. They're important. But then, and crucially, and often what we were never taught at medical school or anywhere else, is how to apply them, and how to apply them at the bedside. And once you know that, it allows you to characterize the controversy, and the old exam saying of classify or die becomes, and still is, very true. And by doing so, it often leads you to some clarity, and that will help you with your decision. It will help you with your communication with the parent teams and other specialties, the multidisciplinary team, but also with the family and the patient. And also can give you a justification so that what you're saying, the reasoning behind it, can be written down and can defend you if any criticism ever comes. Because a good doctor makes good decisions, and better ethics is about having better justifications for those decisions. So our mnemonic and the way we're approaching this topic, and to help us use these sort of objective ways of looking at ethics at the bedside, we use a mnemonic called moral balance. And what does that stand for? Well, the M stands for make sure of the facts. If you're not sure of the facts, it's very hard to move on. And in many ways, just by thinking about those facts, it really helps you work out, why is the hematologist and yourself disagreeing so vehemently. It can give you key insight into that, and it allows you to explore all the options. The other important thing is the outcomes of relevance to the agents involved. And these are all the agents. Obviously, there's the patient and their family, but there's also the other patients in the hospital and your intensive care unit, even perhaps yourself, society. They're all potential have agents with outcomes of relevance to this decision. And then you level out the arguments using the balancing box, and we'll show you how to do that. Because probably the best way and the easiest way of explaining this is to give an example. Okay, it's late Friday afternoon on your intensive care, isn't it always? And then this case comes in. Simon, a 56-year-old male with a past medical history of alcoholism and drug abuse, has suffered a devastating intracranial hemorrhage, and his pupils were fixed on arrival in the emergency department. He's intubated and ventilated. The neurosurgical advice is that Simon has a non-survivable brain injury, and he's not for surgery. Admission would fill your last bed on ICU. And crucially, also, to throw into the mix, your colleague wants to withdraw in the ED. Do you admit? Well, let's start by making sure of the facts. Moral balance. M, make sure of the facts. Simon is going to die. Or is he? See, what we know is that actually prognostication at such an early time in the emergency department can be very difficult. What sort of bleed in his brain is it? Is it a subdural, extradural, subarachnoid hemorrhage, hypertensive bleed? This can all make a difference. What seniority was the neurosurgeon who gave you that advice? He's got alcohol history. Well, sometimes I've seen alcoholics do better than expected. It's almost like the alcohol preconditions the brain for the future insults. There's a drug history. Could he have taken another drug? And that's confounding our ability to make a clear prognostic decision. These are all going through my mind, but I'm trying to work out whether to admit Simon or not. And in fact, is it no wonder then that the US Neurocritical Care Society has recommended determining prognosis from repeat examinations over time, and not to make that decision in the emergency department when we're not always as sure as we need to be. And of course, in the UK, the recent paper by Alex Manara and colleagues, where they really argue strongly if there's a case for stopping the early withdrawal of life-sustaining therapies in patients with the devastating brain injuries in the emergency department. All right, okay, fine. Simon is very, very likely going to die. Okay, we've got that. That's a fact. It's our last bed on ICU. Well, is it? I mean, how do we make our decisions to admit to ICU and with regard to bed capacity? Are we like a hotel or a restaurant? Do we take bookings? Ask you how many days you plan on staying? Well, I wish my patients gave us an idea of how many days they might want to stay when they come to the intensive care. But we're not like a hotel or a restaurant. We don't just put the phone down and say that we're full. We actually try to accommodate all the new referrals, and if they need intensive care, to find ways to deliver it. So it's not like, I'm very sorry, sir, we're full, can you come back tomorrow? Now, in fact, our triage decisions to ICU are not based on current bed capacity, but they're based on physiological potential to benefit, what can be done, and the harm-benefit ratios, what should be done. or at least we try that as much as we can. I don't think outside of pandemic flu, there really is such a thing as the last bed. A better analogy is an ICU is like a taxi queue. If you miss your taxi, and then you see you're waiting in the queue and the last taxi's gone, don't fret. Another one will be around in a few minutes. That's a better analogy. That's what it's like. And to make this point stronger, this is our unit bed flux in Nottingham through ICU in March of this year. And the blue dots represent admissions and the red dots represent a discharge. And you'll see around 5 o'clock in the morning it goes pretty quiet. But for the rest and all the other hours, patients are being admitted and discharged all the time. So if you don't like your current bed state at the moment, go have a cup of coffee. By the time you come back, it'll be different. Now, I know I have a luxury of working in a unit that has 21 level 3 beds and 20 level 2 beds. So we have an economy of scale that allows more movement of patients. But even in smaller units, we have ICU networks, critical care networks, to flex the beds. We often can bring in extra staff, extra nursing staff, and we can sometimes surge into recovery in theatres and other places. And I wonder whether we really do have a last bed. Often there's delayed discharges that are stuck waiting for a normal ward bed. So maybe we can't even say that. But we could probably say as a fact that discharges from ICU will be needed. Right, what are the outcomes of relevance to the agents involved? Well, what matters to Simon? Well, he wants to live. But if we're saying he's not going to live, he wants to be really sure that that was a safe decision, that our prognostication is true. And if he's not living, I'm sure he wants a good death where his end-of-life wishes are respected. What about Simon's family? Well, clearly they'd like him to live. But if he's not going to live, then they'd like him to have no suffering. And they'd like us to care for them. As Robert Buckman so eloquently put it many years ago now, if we do it badly, our patients and families will never forgive us. If we do it well, they will never forget us. And more recently, in 2014, the document One Chance to Get It Right. Okay, what are the other outcomes of relevance to the agents involved? Well, we may not be down to our last bed, but ICU is tight for beds, and we're going to have to be really thinking about discharges and moving patients through out of intensive care and into the wards. And also in this mix, there's a relationship at stake, you and your colleague. And that's very important, because as many people have said, it's not the patients that wear you down, it's often the relationship with your colleagues and their criticism of you or their support of you in these difficult decisions make and break the longevity of your career. And also, what about society? What do they have? What outcomes of relevance do they have to this mix? Well, they clearly are interested that we have no prejudice. Simon comes with an alcohol and drug history. Society demands that we aren't prejudicial to him. Society asks that we deliver quality intensive care. And in the circumstance of Simon's injury, there is a real possibility that organ donation and the benefit that transplantation can bring to society is a possibility that society would like us to explore with him and his family. So, now that we've found those outcomes of relevance, it's time to level out the arguments using the balancing box. And literally, when we're in trouble, Dan and I will actually draw this on a piece of paper. Don't always file it in the notes, but it's somewhere where we can put out, where we can write them all down and then look at it to do some levelling. So, what can we see in the autonomy box? Well, Simon, he's unconscious at the moment, so it's very hard to know. But through his family, we need to try to ascertain what his wishes are, values and beliefs, and how they relate to what he would like in life. But if he's going to die, then what are his end-of-life wishes? What are the benefits? Well, a safety of prognostication is a clear benefit that might come with more time on ICU. And more time on ICU from the emergency department coming up to ICU may allow his palliative care to be better. And also, that may allow more family care, more time for them to come to terms if there is going to be a bad outcome. And there is a benefit, a wider benefit we talked about before, of saving others through organ donation. All those are laid out there. But what about the burdens? Well, he could be left in a persistent vegetative state. That's sort of going through my mind. Maybe the omission, what are the burdens of that? And palliative care, giving him more time for the family, that's a good thing. But what if it drags on? And no one makes a decision. You hand over care and then it's 2 days and 3 days and 4 days and then he dies. Do we help anyone by dragging it out when the death was almost inevitable at the very beginning? And as we said, we may not be down to calling it our last bed, but patients, we're going to have to move our patients through, and we're going to maybe even have to do transfers out, and that risks harm. And there's also potential burden here in your relationship with your colleague. That could be harm today. If you come to blows on this topic, this patient, well, you've got another 10, 15 years, and that still will be going through your mind. And the importance of laying these down is because if you don't acknowledge that, even though it's there in your heart, even though it's nagging you, if you can't acknowledge it, you can't push it to one side and can't focus in on what's really important. And in justice, the other ICU patients in your hospital, beds are tight, we need to distribute our resources fairly. And also the concept of moral distance. Moral distance is like a moral failing where you concentrate on just what's directly in front of you and don't think about the longer term, wider implications of your decisions. And so, there are other patients maybe waiting transplants in other parts of the country. And we talk about critical care without walls, but maybe we need to think about hospitals without walls. And this paper from Australia, recent paper, highlights some of the one metric of QALYs and how actually admission from patients that lead to donation may actually be a very good use of QALYs and resources. But the key is you've laid it all out there, all the things that might be influencing this decision. And then when I do that, I can sort of see some things jump out at me. And they're the ones I want to concentrate on. So I'm not sure what jumps out of you, but what jumps out of me immediately is this concept of safety of prognostication. If I can't get my prognostication right, I can't move on with any of the other aspects. So if I am uncertain about what the outcome is here, I feel very strongly that admission probably is the right thing. The next thing that jumps out of me is the palliative care and the time aspect, because it appears on both the benefits and the burdens. And whenever I see that, I know when they're on both sides, when they seem to be in conflict, that's an area I need to concentrate on, an area I need to put some time, energy and thought in, and also some high communication potentially with the family in this case to balance those two together and get family input and maybe look at the autonomy and how that affects what Simon would wish at this time. It's really powerful when you see them on both sides. The third thing that jumps out at me is other ICU patients in your hospital. We're going to have to put some time into talking to the bed manager, to talking to the nurses, to talking with even senior matron on call, to try to be moving patients through, to get the discharges. And if we don't put that time in, it's all going to become a bottleneck. We need to invest that time. And the fourth thing that jumps out to me is that relationship with your colleague. If we go away today and we don't resolve it, we don't talk about this and come to an agreement, it may really affect our relationship. And it's really showing to me that I've got to spend some time today to maintain that relationship. This has given me a way of progressing. So we could have alternatively, we could be back where we started. Here he is, pupils fixed on arrival in ED, he's intubated and ventilated. It all looks terrible. And we could just write, clinical situation is hopeless, not for ICU. Withdraw care in the ED. Well, we really are withdrawing care, because it really, with those two sentences, have we really shown much care? How quickly did we make that decision? How easy is it to be justified? But I think equally wrong would be just to be write down, admit for organ donation. What? Of all those things at play, that's your answer? That's the only thing that counts? That's the thing that matters? Be careful. Or you might end up like what happened to us when one of my colleagues wrote this in the notes. This is the admission summary. 28-year-old with unsurvivable brain injury for consideration of organ donation. Discharged home. GCS 15 out of 15. I think both decisions and their lack of any justification do very little to address any controversy or any confusion and don't bring a lot of clarity. So alternatively, this is what I suggest. Using our balancing box and seeing the key issues, we might write, on balance, I have decided to admit Simon to the ICU for a period of observed prognostication. We will discuss again with neurosurgery if there is any sign of clinical improvement. That's our safe prognostication. Secondly, you might write, sadly, Simon's death remains the most likely outcome, and we are very likely to commence end-of-life care tonight or tomorrow. When his family attend, I will update them. As part of making a best interest decision for Simon, I will try and ascertain from his family knowledge of Simon's values, wishes and beliefs. I've notified the SNOD team that progression to end-of-life care is very likely. We're addressing that palliative and family care issue we identified. And you might even go further. You might even write in the notes, ICU is currently under considerable bed pressure, but I've escalated this to the hospital manager who is seeking beds for our delayed discharges. I expect Simon to be on the ICU soon, dealing with the other ICU patients. And finally, you might even write, I've discussed the case with my colleague Dr. Smith, and we both have reached agreement that admission to ICU allows the best opportunity to ensure the safety of the MDT prognostication and manage the likely future palliative care needs for Simon and his family, dealing with that relationship with a colleague. But you would only write that if you and Dr. Smith did come to an agreement. But I'm sure Dr. Smith, reading this afterwards, would be very pleased that you'd come to that agreement and actually are included. You've included him or her into that decision. And it's very clear then where everyone's coming from. So a good doctor then makes good decisions. And better ethics, we contend, is about having better justifications for those decisions. But then the sting in the tail comes that day. As once was told to me by one of my charge nurses, don't you think, Dale, you should prioritise the living more than the dead? Or as some people have heard in the country, are you admitting this patient just because you were the clinical lead for organ donation? And you're like, oh man, it's been a really rubbish day. Oh, good. Can I talk to you about how I made my decision and how I used moral balance? And you head home that night and you're sitting there and you're wondering, is it the cup of tea or the glass of wine? Because it all looks pretty grim. But then you think, now, hang on. I made a safe prognostic decision today. Yeah. I delivered a standard of end-of-life care that I would wish for myself or my family. That on my watch, I protected the other patients under my care, and I may even have benefited other patients in my society who are in need. And I've maintained my relationship with my colleague. Do you know what? I'm going to wake up tomorrow, drink some coffee, and go back to work and do more good.